Hey, friends and scholars. Thanks for joining us tonight on Facebook Live. I want to share with you some things we're really excited about at IDM Scholar Society, and it has to do with airway, breathing, and sleep disorders. We have an exciting live event coming up in December with IDM Scholar Society here in St. Petersburg, Florida. And we want to invite you to come participate and be part of an intimate group learning how to implement these things into our practices. And so let me share with you for just a few minutes tonight about what we're going to talk about and some of the things that we're excited about that are so important. And so let's talk about airway breathing and breathing-related sleep disorders and why they are so critically important to dentistry. And they are. More than we have ever dreamed, airway, breathing, and sleep has become a central part of our focus in problem solving. So if we think of the masticatory system and the joints and muscles and occlusion as what we're responsible for in dentistry, we've come to realize just in the last few years that our paradigm is truly shifting, and that we understand that the relationship between the nose and the mouth and breathing is so critically important to our health, but also to the work that we do in dentistry. So let me give you an example. If we think of someone who cannot breathe through their nose, they have allergies, they have congestion, they have a deviated septum, they have some kind of pathology in their nose, then you're going to see things, particularly like in a child who might have allergies. You'll see them breathing with their mouth open. In fact, they will convert to becoming a full-time mouth breather. And I want to show you why that's a big problem. They may have no ability to breathe through their nose if they have things like a deviated septum. And in adults, like we see here with our buddy Napoleon, you begin to see signs in adulthood that are very clear that relate to this problem of mouth breathing, such as the long face and the open mouth and the eyes that look kind of pulled down, the lack of high cheekbones and muscles that are underdeveloped. Here's what we want to focus on is, what does that have to do with dentistry? Well, it has everything to do with dentistry, and both pathology and dysfunction and also diagnosis. So let's draw a line, and that line is going to go from beneath the nose. And now we're going to think about what's happening in the mouth in these people who can't breathe through their noses, whether it's a small child or an adult. Some of the things that can happen are this: you will, through mouth breathing, actually cause inflammation in the back of the throat through breathing dirty air that should be filtered, purified, sterilized through the nose, now going to those small lymph tissues that we call the tonsils and the adenoids, and they can become swollen and inflamed, even infected, because of breathing in dirty air all day long through the mouth. We can see inflammation in the mouth that can happen as a result of that. We see changes in tongue posture, such as mouth breathers showing that they will have not enough room for their tongue. So you'll see scalloped tongues, and often with smaller mouths that can create obstructions. You'll see the soft palate that's going down the back of the throat, and they can develop blockage in the posterior pharyngeal or back of the throat airway. And this blockage we call snoring, or in worst case scenario, we call this sleep apnea. Other things that we see happening below the nose in the mouth are crowding of the teeth in different manifestations, from just an underdeveloped mandible and maxilla to tongue thrusting with the anterior open bite that we can see developing in children. When you see these things, you should be thinking about, could there be an airway problem? Is this someone who's a mouth breather that is being forced to mouth breathe either now or in the past because of upper airway or nasal airway obstruction or difficulty breathing? And what about bruxism? Here we see a young child. Historically, for as long as I can remember, and I've been practicing for 40 years, we've said that when you see a child that bruxes, look in the back of their throat and you're probably going to find swollen tonsils. And that's exactly right. What we didn't realize was, and that also can be a cause of bruxism in trying to open the airway through moving the jaw forward and back across the surfaces of the teeth. And because of that effort to do essentially self-CPR during the night to get the airway open, the teeth may be in the way and the teeth are going to become damaged. And that's true, of course, throughout life. Sometimes we'll see manifestations of upper airway problems through looking at the gingival tissues. This is an 18-year-old, and you can see on the anterior teeth, there's some gingival inflammation. This is very common with someone who's a mouth breather, where they don't get the nice effects of saliva to balance out the pH and to help control bacteria. In this same individual, you can see that in the back of the throat, the uvula is down the back of the throat. This would be a Malin Potty 4, which means that the soft palate is down the back of the throat, which greatly increases the odds of this individual having an airway and sleep disorder. Also, we see swollen tonsils in the same child. This young individual who was diagnosed with TMD, meaning sore muscles, clenching, grinding, and morning headaches, actually had an apnea score that was severe, and yet she was only about 5 feet tall and less than 100 pounds in weight. Not your classic sleep apnea patient, but really now we realize that sleep apnea patients come in all shapes and sizes. Here's another example. A young lady, 21 years old, referred to me for, quote, TMD, unquote, sore muscles, tired muscles, headaches, and fatigue. She actually told me that the week before she came to see us here in St. Petersburg, Florida, she had gone to the emergency room because she woke up in the middle of the night feeling like she was choking to death and was panicked. At the emergency room, they ran EKGs and all kinds of batteries of tests, and they said they found nothing, and they felt she was just having a diagnosis of a panic attack. They gave her medications for anxiety and sent her home. When she came to see us, and we look in her mouth as a dental team, and we have her open her mouth as wide as she can and lift her tongue up as high as she can, I can see 5 different signs of an airway, breathing, and most likely sleep problem. 1 is she has a severe tongue tie. 2 is that her soft palate and uvula are down the back of her throat, a Malin Potty 4. 3 is her upper maxillary arch is omega-shaped, meaning that the premolars and molars are pinched in because the tongue doesn't fill the roof of the mouth and push them out. And so this is classic for a mouth breather. Also, she has a scalloped tongue, which is about 70% associated with some kind of airway breathing disorder. And finally, you can't see this clearly on this one photo, but her number 6, 7, and 8 have significant wear on the incisal edges into dentin. Why is that? Because she goes out edge to edge and even beyond and rubs her teeth aggressively. Why would you do that? That's not a dental occlusion problem. That's not an anterior guidance problem. That's an airway problem in an effort to move the jaw forward to open up the posterior airway and be able to breathe. And so the diagnosis was not panic attack that she caused her to wake up in the middle of the night, but it was because of having an airway and breathing and sleep related problem. We did a home sleep test on her, and her apnea score was in the severe range. Here's a young dentist who comes in to see us and says that he has some issues that are uncomfortable with his bite. He uses nasal sprays daily for congestion in his nose. And when you look at his profile, you begin to see something here, don't you? When you look at an ideal profile overlay over his profile, you see that his maxilla and mandible are severely retruded. He also has crowding in the anteriors. He's beginning to get wear on the anterior teeth. He has a scalloped tongue. All signs of there not being enough room and an underdevelopment of the skeletal framework, that is the maxilla and mandible, that are surrounding the airway and the soft tissue of the tongue and the soft palate and the tonsils. And so you can begin to see where there could be obstruction. We also look inside of his mouth and you see severe tongue tie. You see extremely swollen tonsils. When we look at a CBCT, you see a blocked airway in the nasal area, as well as a very, very narrow airway in the posterior pharyngeal area where it's very much filled with tonsillar tissues. And so, yes, there's a direct overlay here with dentistry and with breathing, airway, and sleep disorders. Here's Audra, and as you look at her profile, you also see that her upper and lower dental arches are retruded, and she has this severe anterior open bite. She has a lifetime history of allergies and nasal obstruction and mouth breathing. And so is this just because of mouth breathing and tongue thrusting? Is that the whole problem for why she's developed this occlusion in which she's now touching on her second molars and wide open in the front? Well, as we look more closely, we've understood that when you see an anterior open bite, when you see a retrusion of the mandible and even the maxilla, another consideration should be, what's the condition of the temporomandibular joints? Are they breaking down and collapsing in such a way that it's creating a retrusion as well? So here's Audra's CBCT, and take a look as I outline the joint on the left side of your screen here, and you can see that her condyles are about 3/4 missing because of breakdown, and she's bone on bone with severe wear in the joint on both the surface of the head of the condyle as well as the fossa and eminence. And so severe retrusion of her mandible because of joint breakdown. And so this is a combination. She has upper airway, nasal obstruction. She has posterior breathing obstruction, and she has joint collapse in the back end, which is all collapsing everything down on her airway. So you see how a TMJ internal derangement and airway dysfunctional breathing can lead to a severe malocclusion. Here's another example of a gentleman who came to see me, and his chief complaint was he didn't like his anterior teeth, and the restorations that had been there had been wearing and chipping, and he wanted to know if they could be replaced. The question, of course, is why are those porcelain restorations wearing and chipping in an edge-to-edge position? Isn't that suspicious for someone who may be functioning out in a forward posture, perhaps because they're trying to open up the posterior airway? And in fact, this isn't just parafunction, which is beside normal function. I would call this protective function, protecting the airway and protecting the ability to breathe and receive oxygen. And so this anterior edge-to-edge wear and this individual who comes in with very mussed up look, doesn't he have, and very enlarged neck. He looks like the poster boy for what we think of as sleep apnea. We look in the back of his throat, and he's a Mallampati 4 with the uvula down the back of the throat, some scalloping of the tongue. Interestingly, he has a history of cardiac arrhythmia, high blood pressure, diabetes, heavy snoring, and bruxism. All of those descriptions are characteristics of airway breathing and sleep disorder. We do an overnight home sleep test, and his apnea score is 68 when 30 is considered severe. He is in great danger in his overall health for having a heart attack due to a lack of oxygen. And yet we're picking this up because of edge-to-edge wear on anterior teeth and what we see in the mouth. Here's another example of a V-shaped maxillary arch, an anterior open bite. We see a profile in which we see maxillomandibular retrusion. This patient has a history of lifelong allergies, chronic fatigue, had been diagnosed with fibromyalgia, high blood pressure, tongue thrust, and severe malocclusion. When we do a sleep test overnight, her apnea score is 43. Remember, severe is 30. They're coming out of the woodwork. We're finding these patients left and right. Here's Bob the Bruxer. Bob the Bruxer has severe wear on his teeth because of parafunction, or what we would call protective function to protect the patency of the airway. But also we see smooth erosion that has to do with low pH. And so the suspicion that we have is perhaps Bob could have sleep apnea and most likely has gastric reflux. In fact, we find that those two things often go hand in hand. Most people with sleep apnea have gastric reflux because as they're trying to breathe through their throat and their airway is obstructed, it creates a negative pressure up from the stomach that can actually release stomach acids up the esophagus and into the oral cavity and even up into the nasal sinuses. And so we do a overnight home sleep test for screening of Bob, and his apnea score is 57. Remember, severe is 30. We're finding people that are very ill overall coming into our dental office on a daily basis with these specific signs and symptoms that we've always seen, but never associated with these things. Here's another individual that comes in, clearly a mouth breather. We see decay on anterior teeth. We see some inflammation of anterior periodontal tissues. He's had lots of work done. He's a bruxer. He shows some signs of smooth acidic wear as well. What's his history? 30 years of bruxism and dental problems and poor sleep and fatigue. In fact, what it is discovered as we look at this severe maxillary retrusion is the fact that he is diagnosed with sleep apnea, gastric reflux, and ultimately developed esophageal cancer, which is directly related to the cause and effect relationship with gastric reflux. This has been happening for over 30 years, undiagnosed. Ultimately, he had his esophagus removed, where basically they pull your stomach up to your throat to reconnect it, and the quality of life goes from a 10 to a 0, and just a tragic outcome. Today, if we saw these signs and symptoms, we would screen through doing an overnight home sleep test. We would send him to the gastroenterologist to evaluate for gastric reflux. We would treat both, and hopefully and most likely he would never, ever develop esophageal cancer. So another part of this whole discussion of breathing and airway obstructions and sleep disorders is the story of nasal breathing and mouth taping. You may have heard of mouth taping, and let me tell you about that. Here's an article written just in the last year or this year, talking about the impact of mouth taping in mouth breathers with mild obstructive sleep apnea. And their conclusion was from this study of 20 subjects was that mouth taping during sleep improved snoring and the severity of sleep apnea in mouth breathers with mild obstructive sleep apnea and with an AHI and snore index being reduced by about half, just through converting the patient from mouth to nasal breathing. The higher level of the baseline apnea score and snore index, the greater the improvement was shown after mouth taping. And it concludes that mouth taping could be an alternative treatment in patients with mild obstructive sleep apnea. Very interesting, isn't it? Patrick McKeon wrote a very fascinating book called The Oxygen Advantage. And in this book, he talks about mouth taping. And as you can read here with me, he talks about the fact that over the years, he's introduced this taping method to thousands of his patients with incredible results. And he says, unless you breathe calmly through your nose at night, you have no idea what it feels like to have a great night's sleep. Taping the mouth at night is a simple but very effective technique. And while it may sound a little strange, it's well worth getting used to. And he's found that you can tape and convert patients that are mouth breathers back to nasal breathing, sometimes after about 3 months. He concludes by saying, wearing tape across the lips during sleep or when alone in your house during the day gradually trains the body to adapt to nasal, which is physiologic breathing, both day and night. Spending a guaranteed 8 hours breathing through your nose while you sleep is an opportune way to re-educate your respiratory center to adjust to a more normal breathing volume. I want to encourage you, if you've never tried mouth taping personally, try it tonight. Just go to the CVS or Walgreens and buy paper tape and put it across your lips maybe 30 minutes before you go to bed, and make sure you're comfortable with that. And then with that, we'll see if you won't experience the same improvements that we're discussing. I'm having trouble forwarding for some reason. My computer isn't forwarding. Okay. Let's try this. There we go. So the subject here really is about nitric oxide. Nitric oxide is a very important molecule in the body that signals the cardiovascular system and actually dilates your vascular system, but it also dilates your airway. And so the question is, where does nitric oxide come from? And how do we utilize it in our body to help improve our cardiovascular health, but I would say also our airway, our respiratory health? Nitric oxide is created in a number of ways. One of the ways is it's created in the lining or epithelial lining of the sinuses next to your nose. And so when you breathe through your nose, you actually release nitric oxide into your nasal passages and all the way down through your respiratory tract. And so we find that healthy paranasal sinuses, their epithelium expresses nitric oxide synthase, which continually generates large amounts of nitric oxide. This is a gas that is potent for both dilating the airway all the way through, and it also kills bacteria on contact. So you can see if we're breathing in dirty microbes and we breathe through our noses, we actually can deal with them through the nose in its purification, sterilization, and largely related to the effects of nitric oxide. Nitric oxide also can be gleaned from nitrates and nitrites that are found naturally in our foods. And so you've heard of things like kale and arugula being good for your cardiovascular health, and these other vegetables, Swiss chard, spinach, beets, cabbage, cauliflower, carrots, and broccoli particularly, are rich in nitrates and nitrites. And what happens is those are converted into nitric oxide in the body. One of the things, though, that we see is through the years, we actually deplete our production of nitric oxide. And that's really a part of aging and breakdown of cardiovascular health. You can measure your nitric oxide levels by getting test strips. Here, Berkeley Labs makes test strips like litmus paper. You just put in your mouth and put your saliva on that test strip, and then you'll see the color change, either very mildly pink all the way through a bright pink, that tells you whether your nitric oxide levels are depleted or at a threshold or high level. And so here's an example of someone who had done this test, and at first they were very depleted, and then they simply mouth taped at night and checked their levels after several days, and their pinker levels or their higher levels of nitric oxide went up. And then they added supplementation, which you can purchase. Here's an example through Berkeley Life of nitric oxide support, nitrate tablets. And through that, in combination with mouth taping, you can see this individual went to a high level of nitric oxide levels. And so if you want to boost nitric oxide levels and increase both your respiratory as well as your cardiovascular health, eat nitrogen-rich foods that we've pointed out, practice nasal breathing during the daytime and mouth taping to encourage nasal breathing at night. You can take nitric oxide supplementation. And fourthly, you can have a healthy oral microbiome. In other words, in your mouth, when your mouth bacteria are healthy, on your tongue, you'll actually convert nitrates to nitric oxide through the interaction with good, healthy, symbiotic bacteria that are commensal to our health, and will send that down our digestive tract and into our bloodstream through our digestive tract. And so this is all part of one bigger story. This bigger story we call integrative dental medicine. In that, the three pillars of integrative dental medicine are airway, sleep, that we just talked about, inflammation and infection, and then also temporomandibular disorders and malocclusion. Here's the big discovery that we've made, and that's this, that inflammation and infection, both in the mouth and systemically, airway, breathing, and sleep disorders, and TMD and malocclusions are linked to each other. And that's the big story for dentistry, is that practicing dental medicine has to include awareness and observation and diagnosis of airway, breathing, and sleep disorders, as well as the health of the temporomandibular joints, as we looked at in Audra's case. And so how do we learn about this? Well, and how do we implement this? We at the Integrative Dental Medicine Scholar Society have created a checklist you see here that at the top has the 3 different pillars I just mentioned. And if, for example, our challenge were this, the first procedure performed by every dentist for every patient of any age should be a proper airway exam and evaluation of breathing function. Our primary duty as dental professionals is to promote proper breathing and general health for every patient that we see. So how do we integrate that into our dental practices? Well, I would suggest we can use this checklist, and right there in the center column, you see screening information, clinical observation, screening and testing possibilities, and even on the next page, we see treatment options that we have for managing and resolving airway, breathing, and sleep disorders. And so that's what we're all about at IDM Scholar Society. If you'd like to receive the checklist that I just showed you, all you have to do is go to your phone and open up your text and put in 22828 and text in integrative at 22828, and it will ask for your email address and send you that checklist that you can begin studying and looking at right away. But I want to invite you tonight, as we conclude, to an upcoming airway and sleep workshop. We're holding this December 2nd and 3rd in St. Petersburg, Florida, through the IDM Scholar Society. The idea and purpose of this 2-day workshop is to introduce all of us in dentistry and in medicine to ways of implementing airway, breathing, and sleep disorders into our practices. We're going to build a model from the ground up. We're going to divide our workshop into 14 step-by-step, layer-by-layer, easy-to-follow sessions. We're going to talk about anatomy and physiology and pathophysiology. We're going to talk about screening and testing and treatment and referrals and collaboration. We're going to talk about marketing and business strategies and much more. The bottom line of this workshop is going to be that our goal is that even the most novice attendee will be able to grasp and apply these lessons that we'll be teaching and practicing through the workshop, including overnight home studies and learning about different oral appliance options that we may have. We're going to have people there to assist us with expertise on these things, and we're going to do workshops and simulations while we're together. So that is December 2nd and 3rd, right here in St. Petersburg, Florida. And if you'll just go online to www.idmscholarsociety.com/sleep workshop, then you'll be able to learn more and have the opportunity to register and join us. We have room for a handful more. We're only going to limit this class to 30 people. We're getting there, but I wanted to make sure I sent this out to our friends and colleagues that are very interested in this, that you will have this opportunity to learn about this very soon. So I hope you'll come join us December 2nd and 3rd here in beautiful St. Petersburg, Florida. We're going to be meeting at the Piper Education and Research Center, a beautiful facility, and have an intense 2 days of learning together. So hope to see you then and look forward to getting together. Take care, and thanks for joining me tonight. Take care now. Good night.